right. Well, good morning and welcome to our session on management of depression in older adults. My name is Raquel Meyer, and I have the pleasure of introducing Dr. Rob Madden, who is facilitating this webinar today on behalf of the Ontario Centres for Learning, Research and Innovation in Long-Term Care. So we encourage you to go to our website to discover the multitude of resources that are available to you. And I'd like to introduce Dr. Rob Madden today. He is our Chief of Psychiatry and Executive Medical Director for the Centre for Mental Health at Baycrest. He is a geriatric psychiatrist and an expert in non-pharm approaches for treatment of BPSD in our elders. So Dr. Madden, thank you for joining us, and over to you.
Okay, thank you, Raquel. So welcome, everybody. It's a pleasure to do this, and I was happy to be asked to give you a talk on depression in older adults. I really want to make this interactive. We have an hour, but I don't have an hour's worth of material. I purposefully left lots of time to leave for questions and answers. You can ask questions through the chat box or the question tab, and Raquel and I will try and keep track of that. And if they come in fast and furious, I'll certainly need some help with that, Raquel. And I'll take pauses and breaks between sections. So please don't hesitate to ask questions. I want to make this relevant for you. And starting off, and you can start sending in your responses, and I've already seen some of what your goals are. But if there are specific things that you want to know, please send that in. Please type away, and I'll try to address everything that I can in the time that we have. So, by the end of the session, I'd like you to be able to list the various disorders that can present with depressed mood in older adults, describe what a workup would be like for depression in late life, and then list some evidence-based treatments. So we'll go through assessment, medications, and other treatments. So what's important is the differential diagnosis for someone who says that they feel down or they feel sad. You might automatically think, well, maybe it's depression, but there's a whole bunch of things it could be actually. And here's a list that I came up with. So we have in the top corner here, major depressive episode, major depressive disorder. So you want to call that clinical depression, you can. But then there's an important differential diagnosis, which is bipolar disorder. People with bipolar disorder can develop depression, and they also develop mania or hypomania. If someone presents to me with depression at any age, I always consider that it should be bipolar depression until proven otherwise. So as part of the clinical assessment, it's really important to try and rule out episodes of mania or hypomania. If you have somebody with bipolar depression and you start treating them with antidepressants, they might switch into a manic or hypomanic episode, which is not good. So it's an important differential diagnosis, and the treatment's quite different. There's something the DSM-5 called persistent depressive disorder, and that's more like chronic depression, like a long major depressive episode, or there's something called pure dysthymic type, where you don't quite meet the threshold for a clinical major depressive episode. You don't have enough symptoms, but you have some, and it goes on for about 2 years or more. And that's called pure dysthymic type. There's a minor or subthreshold depression. So again, that's a type of depression that's pretty common in older adults. In fact, it's more common to major depressive disorder. It's when you have, again, some symptoms of depression, but they don't fully meet the criteria, and they don't meet the criteria for the dysthymic disorder. And that's actually very common. We see depressive symptoms in long-term care at a huge rate, about 40 or 50%. In hospitals, in doctors' offices, the rates are about 25, 30%. So we're seeing lots of subthreshold depression, and the rates of that exceed that of a major depressive episode. There's the adjustment disorder, which means that you're feeling sad. You have some sadness related to something, a stressor, so you're having trouble adjusting. Bereavement, so grief. Personality disorders that present with depressed moods, for example, borderline personality disorder, mood disorders secondary to medical conditions, and substance use. That there are substances that could make you present as though you have depression, and we'll go through some of these things. So good for you to be aware of that there's a broad differential diagnosis, and certainly the ones that could really throw you is if the person actually has a bipolar disorder, if it was a personality or medical condition or medication, that really changes how you're going to approach the problem. So these are the symptoms in the DSM-5 for major depressive episode. The ones with the asterisks.
Yes. Rob, may I interrupt? I just think we have maybe a muting problem. I'm not sure that everybody can hear you. So I just want to make sure that your little phone icon is green and people can hear you.
On my phone, there is no mute. And on the screen, I don't know what I should be looking for on the screen.
Under that orange arrow in the box?
Yeah, it's green. People can hear you. Yes.
People can hear you. Okay. I'm going to press *1. Oh, I can hear it well, FYI. Okay, so please do call in if you're not hearing it through your computer. Okay. So, thank you, Katie.
Thank you. Yeah, okay. If you missed the last few slides, then you could take a look at them, and it was just some background about depression. If you're having any problems hearing, please let us know. So on the screen, you're seeing symptoms of depression. There's 2 with an asterisk next to it. Sorry. With the asterisk next to it. So you need to have at least one of these 2 symptoms to have a diagnosis of a major depressive episode: depressed or empty mood, or anhedonia, which is really a lack of interest or pleasure in things. Okay, so some people will report that they don't feel depressed, but they just have no interest or enjoyment. So that you need to have at least one of those symptoms. So you could have depression without feeling sad or reporting that, although you may look sad to others. Then there's other symptoms like sleep and appetite, which can be increased or decreased, reduced energy, poor concentration, guilt or worthlessness. So those are cognitive, negative cognitive distortions usually. Psychomotor slowing or restlessness. These are like a slowed down thing. Then thoughts of death or suicide. The symptoms need to cause distress or an impairment in functioning, and it needs to last at least 2 weeks. And you should know that depression never lasts only 2 weeks. You need to have it for at least 2 weeks, but depression usually lasts for months. But this is what the DSM says, at least 2 weeks. Then there's a question about dementia. So many of you, if not all of you, are going to be seeing people with cognitive impairment and people with dementia or major neurocognitive disorder. And there are challenges in making the diagnosis, because if you look back at the symptoms I just talked about, you're going to be asking people, tell me about the symptoms you've had over the last while. And someone with dementia who has a memory impairment is going to have a hard time telling you exactly what the symptoms were. Without an informant report, it's going to be hard, because a person with dementia is going to give you a report on how they're doing right then at the moment. They won't be able to answer questions that accurately, and they won't give you valid data with which to make a clinical diagnosis. So people with dementia may not be able to recall or articulate or describe, depending on their language abilities. There's always the issue of whether or not they have a loss of interest versus a loss of ability. So, for example, people might say, "Well, I've stopped playing cards with my friends. I've stopped playing bridge, let's say." Well, why is that? Is that because they're not interested, or is it because of their cognitive impairment? And very often it's the latter. It's the cognition that's the issue. There's issues with sleep and appetite often already in dementia, so these are confounded. And there's psychomotor changes in dementia. So in other words, a lot of the symptoms of dementia either of depression are confounded by dementia, and the data you might not actually believe. You're not sure if it's valid or reliable. There was some research into the depression of dementia, coming up with clinical criteria that'd be different in the DSM. If you look at the research, if you use the DSM criteria, versus the DAD, Depression of Dementia criteria, you'll be able to diagnose a lot more people using the DAD criteria because they're a bit looser and it's more in keeping with what you actually see with people with dementia. So this is Olin and other authors. So instead of 5 symptoms, you need 3. The symptoms don't need to be every day. They could fluctuate a bit. There's the addition of irritability as a potential symptom instead of depressed affect or mood. And they added social isolation or withdrawal. So you could, people who maybe once were more participatory, now they've decided to withdraw from things and isolate themselves. That's another symptom. So if you look at the research, if you use the Depression of Dementia criteria, you'll pick up more cases, and that's of interest. So in terms of an assessment, what you'll see happen is a clinical interview, whether it's done by, it can be done by any healthcare practitioner, but the interview trying to again rule out some of the other disorders and rule in depression. Getting collateral or informant history is going to be important. It's important because someone with a bipolar disorder may not offer up or recognize or remember that they were high at one point. So it's good to get an informant history because they might tell you. That happens all the time to me in the clinic. Also, people with substance use and addictions may downplay that. People with some cognitive impairment may not be able to provide an accurate history. People who have psychosis in the context of their depression may not recognize it as well. So we ask in our clinics that an informant always comes. It's very important. Assessing safety, so suicidal ideation, and depending on the situation, assessment of thoughts of harming others, but certainly suicide. A cognitive assessment is an important part when you're doing an assessment of any older adults, because people could have pretty good social graces, but not do well on cognitive testing. And you see that. You see people who are pretty nice and can have a kind of pleasant conversation, but we start assessing the cognition, it falls apart. Sometimes a focused physical exam, depending on the situation. Sometimes blood work. In particular, people who are treatment refractory, treatment resistant. At a certain point, I decide, let me check something. And there was a person once where her symptoms of depression improved, but her energy still was terrible. And I decided to do this blood work and found a very low B12 level, very, very low. It's for 47. That's a very low level. Treated the B12 deficiency, she got much better. I have a patient right now, same thing, and I decided to do some blood work and found that there was a thyroid dysfunction, hypothyroidism. The TSH was quite high. So there's a time and place to do blood work. There's a time and place to do neuroimaging, whether it's an MRI or CT. Those are often reserved for people, again, where the presentation is atypical. There's cognitive impairment concurrently that you're concerned that might be it's stroke or dementia. You want to rule out other things. So it's not routinely done, but it could be part of the assessment. And driving is often part of the assessment. I assess people's driving. I ask about driving at every clinical interview when I see a new patient. People with depression may not be able to drive. Some people voluntarily stop driving when they're depressed because of their inability to attend to things, their poor attention, and sometimes frontal executive dysfunction. So the multitasking that's involved and necessary for driving. So I ask people about motor vehicle accidents, crashes in the last year or 6 months to a year during the time they've been depressed. And there have been sometimes that I've actually written to the Ministry of Transportation reporting a medical condition. It's not dementia, but sometimes other mental health disorders can lead to the difficulties and challenges in driving. So that's the general assessment. I like using rating scales, and measurement-based care is important. I mean, we measure lots of things in medicine. We measure blood pressures and hemoglobin A1Cs and get up and go test, and there's all sorts of things that you measure, and there are valid and reliable tools to measure mental health symptoms for different diagnoses, including depression. The screening tool that's often used is the geriatric depression scale. We often use 15 item. There's even a scale that has fewer items, and it's valid and reliable. And the questions are yes/no questions based on how they've been in the last, I can't remember if it's a week or 2 weeks. And it's a screening instrument. It's not meant to track. And it says, again, it's got the sensitivity. So if you get a score on that, it's going to trigger you to do an assessment. We use the PHQ-9 a lot, the Patient Health Questionnaire. It really just mirrors the DSM-5 criteria. It's how you've been over the last 2 weeks. You've got your 9 symptoms, and then you go ahead and rate it if the symptoms have been there not at all, several days, or like almost every day. So that's it's just like kind of like a Likert scale. You get a score at the end, and it measures your distress, and that's used to help with diagnosis and tracking. And so over time, I like to use the PHQ-9 to see where people are at, and a response to treatment would be at least 50% improvement on the scale, and remission would be no symptoms. There's other scales like the Montgomery-Åsberg Depression Rating Scale. There's the Beck Depression Scale. Those are used as well. They're different and a bit longer. And in people with dementia, you can use the Cornell Scale for depression and dementia, because what I said before is that people with dementia will have a hard time providing you with accurate information because of the cognitive impairment. But you could try the Cornell Scale. It gives you an inventory of their symptoms, and it's an informant interview, basically. So you will be using the scale on someone who knows the person with dementia well. Okay. So I see that there's no questions as of yet. I'm going to pause here for a second. If you have any questions so far, I'd be happy to hear what they are. I'll just give you a few seconds in case you want to try typing. Okay, so I think I'll move on.
Yeah, feel free to use the question box or the chat box. We're looking at both. And also, I've just inputted into both of those sections a PHQ-9 resource that you can access through the Ontario CLRI website for free. It is a training toolkit to help educators and long-term care trained staff on screening for depression, and it includes simulation videos for practice. So please check that out. Thanks, Rob.
Okay, thank you. Okay, so we'll move on, but please, if there's any questions or comments, go ahead and post those, and we'll get to them. So we'll talk a bit about medication, psychotherapy, and other things. So before we talk about treatment, I wanted to bring this to your attention. So this is the biopsychosocial formulation grid. I don't know if you've ever heard of it or seen it before. It's how, in medicine, how we try and understand the patient and why they're sick now. It's used a lot in family medicine and in psychiatry, but it can be used in all aspects of medicine. It's particularly useful in psychiatry and in geriatric psychiatry. And what you're looking at are various factors that could, contribute to the person's illness right now, and help you understand how they got there and why they're sick now. And it will inform your treatment. So the whole reason to do this formulation is to help you come up with a treatment plan. So biological factors have to do with like genetic factors, medical conditions, substances, and that sort of thing. Psychological factors have to do with the psychological issues that people have. Their emotional and psychological views, their beliefs, so that's where you have things like trust, intimacy, self-esteem, autonomy, all sorts of themes that come up. And social factors are social factors. So, housing, finances, supports, et cetera, et cetera. And we look at this in terms of what the predisposing factors are. So, things that would make you vulnerable to developing whatever you have, okay? So biological predisposing factors could be, again, something genetic, difficulties with the person's birth when they were delivered, early childhood, diseases. So predisposing factors. Then there's social factors and sort of the environment, like I've told you about. and that would cause some sort of psychological issue, right? So you could talk about social factors, people who, let's say were abused, that would, cause some psychological, way of seeing the world or themselves. Precipitating has to do with what's precipitated the most recent episode, biological, psychological, social, what perpetuates your illness, what keeps it going, and then what the protective factors are, again, biological, psychological, and social. So the treatment will jump out of this, because if you think that, for example, biological perpetuating factor is non-adherence to medication, the person doesn't take their medication, well, you're gonna work with that. If you find that there's a lot of social turmoil because of disputes and conflicts, you're going to have to deal with that. If you see that the person psychologically has issues with trust, that's going to be very helpful in trying to understand the person and work with them in a therapeutic relationship. Okay, so I will get back to this. We're going to run through a case later, and I'll bring up the formulation to show you how it would work.
Dr. Madden, I think we have a question with respect to screening. Kathy's asking if you think most to all doctors in long-term care homes screen for depression.
Sorry, Rick, can you repeat the question?
Sorry, do you think most to all doctors in
in long-term care, most of the time, and I think it's a requirement that people are screened for depression through with the MDS. I think there's a bunch of questions. I think there should be a high index of suspicion for residents of long-term care that there could be depression, and again, even minor depression with fewer symptoms. So I think there's a high index of suspicion. I know in our long-term care facility, on admission, there is a screening instrument that's used by nursing staff, and that would be reported to the physician if there was a positive response that they thought that there was depression. I don't know what it's like in all districts, whether or not it's mandatory. I don't have that information, but I would think that it would be just like when you do the screening, your initial physical exam for someone admitted to long-term care. It would make sense to also assess mood. So that's a good question. Okay.
Another question. So are these assessments being completed on admission?
So that would be one time point to do it in long-term care. It would be on admission. And at any other point when you think that there's a need to do it, right? So at some point, and it could be years later or many months later, if someone's looking like they're developing depression, you could go ahead and use a screening instrument. So again, on admission, if you're doing your physical exam and developing your formulation of the person, that's a good time to do it. And it doesn't need to be the physician who's doing it, obviously. It's often going to be part of a nursing assessment, or it could be others who do it, depending on the nursing home and how it works. Okay, so we're going to move on. We'll talk a bit about the medications for those who are interested. It's good for you to know a bit about the medications, just because you'll see people on medications, and lots of questions come up about it, and the story of the medications is interesting. There's lots of antidepressants. There's the serotonin reuptake inhibitors. That's the old Prozac family, but that's like citalopram or Celexa, Cipralex, escitalopram, Zoloft, sertraline, Paxil. Then there's venlafaxine and duloxetine, which increase both serotonin and norepinephrine in the synapse. And then we've got bupropion, which is Wellbutrin, mirtazapine, which is Remeron. These all work a little differently. This is a dopamine sort of modulator. This also increases serotonin and norepinephrine through different mechanisms than the above medications. It's the old antidepressants, the tricyclic antidepressants from the 70s and 80s that were used. pills that rhyme with iptaline, like nortriptyline and amitriptyline. There's monoamine oxidase inhibitors. So there's lots of different medications. This is not even the exhaustive list. There's some new ones. We've been working here all across the country and on the new Canadian Coalition for Seniors Mental Health Guidelines for treatment of depression, and I was charged with writing the section and updating the section on pharmacological intervention. And so I had to look at all the studies and read them, and wanted to find out were there positive randomized controlled trials, and what are they? What is the level of evidence for medications in depression in late life? And I see there's, in terms of the row for positive studies, there's a lot of medications here that you use that actually don't have, positive studies, like citalopram, bupropion, venlafaxine. In fact, there's negative studies for citalopram. There's some negative studies for escitalopram. These are widely used medications. Fluoxetine has some positive, some negative. Some are equivocal. This is a drug company study. There's only one, and it's just kind of a small study. So when you look at this, you stand back. These are randomized placebo-controlled trials, and it was sort of well done. You see duloxetine actually has quite a bit of evidence. Again, the studies were done by drug companies, but the studies are well done, very well done. You can't really argue with them. So some evidence there, and we see paroxetine, which no one really ever uses because of the drug interactions and a bit of anticholinergicity. We see one study for an antipsychotic, which was a phase 3 study, very small. One positive study for sertraline, which is Zoloft, tianeptine, which I don't know is even available here. So it's sort of disappointing in a way. So there's a lot of medications here that you'd like to use, but there's not a lot of evidence, and sometimes the evidence is negative. But you say, well, maybe duloxetine looks like a good try, and give that a try. And sertraline is pretty clean, does cause drug interactions. Maybe that would be good. Quetiapine is an antipsychotic that can cause metabolic syndrome and tardive dyskinesia, so maybe you'd avoid that. So it's interesting. And then if you look at meta-analyses, that's where you pull all of these randomized trials together. The newer antidepressants are found to be effective on a whole as a group, more than placebo by about 10%. And the tricyclics and SSRIs were better than placebo. Numbers needed to treat to get one person better were 14 to end up in remission, 6.7 for a response. And that's not too bad. So you treat 6.7 people to get them 50% better. And again, sertraline, which I mentioned, paroxetine, which had some positive studies, and duloxetine were found to be better than placebo to achieve a partial response. And duloxetine better than placebo again. So, there's evidence from meta-analyses that these medications could be effective. Then there's these studies where you treat people and you try and prevent relapse by getting them to continue the medication, or you give them a placebo and they don't know what they're getting, either placebo or medication. So you're just trying to prevent relapse once they're better, and we find some great results for escitalopram. Again, there wasn't randomized evidence for escitalopram, but we see that the risk of relapse was 4 times higher for the placebo group rather than the escitalopram group. So certainly doing something. Citalopram as well, even though it was a negative study for acute treatment. Then there's the systematic reviews, Cochrane reviews, other types of reviews. Sorry, not Cochrane, it's other reviews by Kleisner and Koch. Ongoing treatment is efficacious preventing relapse. Number needed to treat about 5. We know from other studies, classic studies done in Pittsburgh in the 90s and early 2000s, that the continuation, people's relapse rate is much higher when you stop an antidepressant. So getting them better is one thing, preventing relapse is something else. The recommendations, it seems that, and again, available and easy to prescribe, and we have experience with duloxetine and sertraline would be good first-line medications. Duloxetine has the added benefit of having analgesic properties, so there's good evidence for its effect on pain. So it could be great for older adults if it works. You may consider the escitalopram, which is, again, there's some evidence about the relapse prevention, but there's the issues around the QTC interval. Health Canada came out with a warning. If you exceed 10 milligrams, there could be problems with the medication causing torsades de pointe, which is a fatal dysrhythmia. it's a bit controversial as to whether or not we really need to, not use the medication versus check cardiograms along the way. People do things differently. I use the medication all the time. If I have to push the dosage, I just check the electrocardiogram. So there is some complexity to using these medications. How long do you stay on it? Again, no one's ever done these studies for life, like, be on a medication and follow up in 30 or 40 years. There's no such study. The studies tend to be shorter. It's recommended a minimum of 1 year, even in the case of a single episode. The Cochrane review in 2016 showed poor quality of evidence, only 3 RCTs, but from that they found to prevent a recurrence, you just do continuation treatment, 5. So 5 treatments for 1 recurrence. Again, it's not bad odds. The authors suggest continue the antidepressant for 12 months. It appears to be helpful with no increase in harms. And this other author, Raji, colleague, 3 years for 3 years and up. So it really depends. The question that's posed, and even with these classic studies, some people had mild or moderate depression first episode, and there was a high rate of recurrence when they stopped the medication. What I tell patients is just take it. And we would stop it only if there was some very good reason to stop it, like a terrible side effect or if it stopped working. I think that's a reason to stop the medication. So most of us will recommend maintenance treatment. So if people decide that they want to come off their medication, it usually ends badly. When I see people who stop their medication, it usually ends badly. Okay, any questions or comments at this point about the medications or anything else? Okay. All right. Well, if some questions or comments come in, this is a picture of Banff. This is in Banff. This is downtown Banff on the Strip. We went to the CAGP, Canadian Academy for Geriatric Psychiatry conference. There's a conference with the Canadian Coalition for Seniors Mental Health. This is an annual conference. It's a great conference. I encourage you to consider going. And there's a wonderful group of people who have interest in geriatric psychiatry, great presentations, posters, plenaries, social events, charity events. So I encourage you to go. I think the meeting this year is in Montreal, if I'm not mistaken. So there's also something called depression with psychotic features. Just want you to know, psychosis means there's a delusion or hallucination. A delusion is when you believe something to be true when it's not. So a paranoid delusion or persecutory delusion would be, they're spying on me, people are organizing something against me, people are stealing. So those are the paranoid delusions. Hallucinations are sensory experiences like hearing voices when there's nobody around. So people could have psychotic depression. Often the delusions are very negative, like my insides are rotting or I'm poor, like something terrible like that, like nihilistic. For that disorder, the first-line treatment is electroconvulsive therapy. It's a severe form of depression. There is a study called the STOP-PD study, which used medications, and they found higher remission rates after 12 weeks of treatment with olanzapine, which is an antipsychotic, along with sertraline, compared to olanzapine with placebo. Again, what it shows is that olanzapine combined with an antidepressant did cause improvement, but I think typically now, unless the patient refuses or is not eligible, ECT still remains pretty much the first-line treatment. This is often, these patients are often ending up in hospital. My last patient, she lives in the nursing home, and she has bipolar disorder, but she ended up with a severe episode of depression with psychotic features. She stopped eating because she thought she was being poisoned. So, of course she ended up in hospital and she got ECT, electroconvulsive therapy, which I'll talk about in a bit. There's a terrible version of depression called depression, major depression with anxious distress, and that's what people present with. And the chief complaint is often going to be anxiety. But when you start getting into taking the history, you find that person has major depression, and concurrently with that, as the depression started up, they ended up with depression at the same time. Anxiety at the same time as the depression. So this could be someone who maybe isn't typically anxious, but when they get depressed, they get very, very, very anxious. There's a poor response to treatments for this type of episode of depression. It takes longer to get people better, longer time to response. People withdraw and stop their medications earlier because they're anxious. And people who are very anxious, it's hard to get them to stay on the medication because they attribute their symptoms of anxiety, which are often physical, to the medication. They say they're having side effects. And I've got patients like this. I'm seeing one later today. Hard to keep the person on the medication because they're so anxious. You know, they have so many sort of somatic complaints and so anxious, they just think it's from the medicine, so they stop it. So these are people who've been on every antidepressant for one day, right? 1 or 2 days, and they stopped it. And maybe you've never had an adequate trial. Adequate trial of an antidepressant is 6 weeks at escalating and adequate doses. So people with anxious depression tend not to. Very severe presentation of depression, poor social functioning, higher suicidal ideation and somatic symptoms, and shorter time to relapse if your anxiety is residual. So sometimes you treat the depression, they have leftover anxiety, it's a bad sign. The approach is really first to look to see if there's anything else that could be causing the anxiety. There's a list of things, different medical conditions, substance withdrawal, different malignancies, all sorts of other things. And often this is not the case. You don't find anything. Maybe benzodiazepine withdrawal, maybe. You can see that sometimes people who play around with their benzos. But otherwise, you usually end up with a case of aiming high in terms of the dosage, getting up to a higher dose, and treating for a longer period of time to get the person better. And we found that, there's not a lot of evidence. There's a post hoc analysis that found that duloxetine was helpful. So there's some evidence, but there's not a lot of evidence. In other words, what you're left with is you're going to throw everything you got at them, maybe not the whole kitchen sink, but a lot of high dose, longer treatment times, sometimes combinations of therapy to try and get the person better in addition to the psychotherapy. We should also know about depression is treatment resistance. So only about half of elderly patients respond to the first-line treatments, and less than 40% meet the goal, the remission goal, 0 symptoms. In other words, a lot of what we do in treating people, older adults with depression, is treating people who are treatment refractory or have partial remission. And family doctors are great at, and nurse practitioners are great at starting an antidepressant. And if the patient responds good, it becomes more complicated after that in terms of what to do if someone's not responding or have partial response. Those are the types of patients that usually end up seeing a psychiatrist. So the approach if someone's sick or got sick again or had a recurrence is to assess medication adherence. It's always the first thing, all right? And that's a biological factor in the formulation. So are they taking the medication? Are there drugs or alcohol on board? Review the diagnosis, there's treatment resistant. Look for drug interactions and medical conditions. Even hyponatremia, a lot of antidepressants cause low sodium levels, 10% chance for SSRIs and SNRIs. So much treatment resistance, you're looking at adherence, substances, meds, review the diagnosis, look for interactions and medical conditions. This is just FYI, but some authors, Dr. Moussant and others, put together sort of algorithms to treat depression. So you can take a look at this. Basically, it's starting with medications and then switching or combining depending on what you end up with.
So Rob, thank you. We do have some questions in the question box.
Great.
Do you want me to read them or can you see them a bit longer? So Kathy's asking, if there's any benefit.
So there's a question, any benefit to having some type of support group for those individuals who have both depression and dementia. Okay, so we will get to that. Will you be touching on some of the non-pharmacological therapeutic approaches helping individuals who have both depression and dementia? Let's hold that to the next section. I think we'll be able to answer that. Okay, is there another question that I've missed anything, Raquel?
So above that one, there's one, any benefit to having some type of support group for those with maybe mild to medium depression so that they can be with others in the home going through the same thing? And as a frontline staff, how do you talk or support a person with depression and long-term care to check in, et cetera?
Okay, it's a good question. So let's get to that after my next section, because we'll talk about psychotherapy a little bit. The answer is yes, there's benefits to that. Evidence is one thing. Real world effectiveness is something else. So we'll talk a bit about that. Okay, so thanks. We're going to answer those questions in a minute. Just to let you know, for these other types of depression, minor depression, which I told you is a bit more common than major depressive episode, there's not a lot of evidence for treatment, which is unfortunate. Its treatments have been kind of negative. One treatment with fluoxetine was negative. So, and for depression and dementia, medications, it's really unclear. In fact, there's equal amounts of positive and negative studies. So there's not really good evidence for medications for depression in dementia. So in long-term care, that's what you're going to see often, right? Depression and dementia. There's no evidence really that antidepressants are useful. Studies are equally positive and negative, which is a problem. And then we get to, well, what are the interventions that we can use? I told you that we would talk about electroconvulsive therapy. I'll just tell you about it briefly, unless there's more questions. It's indicated for a variety of mental health illnesses, depression being one of them, bipolar or unipolar depression, any kind of depression. It's particularly useful for trying to get someone to have a rapid response. So if you have somebody who's really not eating, not drinking, not taking their medication, kind of wasting away, you need to treat them fast, and there's just going to be imminent risk. Electroconvulsive therapy, they'll probably need to be hospitalized, and electroconvulsive therapy works quickly. It works quicker than medications. People who have the depression with psychosis, and then there's people who are treatment refractory. In other words, they don't get better from antidepressants. They'll often go to ECT. People with catatonia with their depression. And for some people, just it's preference. They've tried antidepressants, it hasn't worked for them. They prefer ECT, and if they get sick, they say, "Give me ECT, please." It's a safe procedure. It's very effective. The efficacy is higher than that of medications, particularly for people who are non-responders to medications. You still get a pretty good response. And in terms of the risks are quite minimal. And there's not a lot of absolute contraindications. It can be done as an outpatient or as an inpatient. Yes, there is some effect on memory and cognition. There is the whole issue about getting anesthesia, and there's the complications around that. But there's not really major contraindications. So it's a tool that's essential in treating geriatric depression and used a lot. Okay. There's even evidence for using it now for people with responsive behaviors who are treatment refractory, and you'll see that in integrated pathways. There's TMS, which was magnetic stimulation of parts of the brain that are involved in mood regulation, and there's some evidence that's emerged for treating late life depression with TMS. It's non-invasive. You have to go usually every day for something like 4 to 6 weeks, 5 days a week usually, and they stimulate parts of the brain with magnetic stimulation. So it's not invasive, but it doesn't have the same efficacy as ECT. We're hoping it will be the next ECT, but it's not. Then there's psychotherapy. So you guys had questions about, is there value in group therapy for older adults in long-term care with or without dementia? The answer is yes. I mean, there's evidence-based psychotherapies And then there's everything else that we do that really hasn't been studied, and we're not sure if there's evidence, but we think that it's beneficial. The evidence around psychotherapy is really around cognitive behavioral therapy and problem-solving therapy. And cognitive behavioral therapy is useful, but you have to have the cognitive ability to understand abstract concepts. And it can be a little harder sometimes with older adults, where you might be doing a bit more behavioral therapy and behavioral activation and that sort of thing, deep breathing and relaxation techniques and activation, and maybe slightly less in terms of the thought records and addressing cognitive distortions and core beliefs. It still could be done with older adults. It's just a matter of choosing your customer wisely, because sometimes it will tax them in a way that they're not used to if they have cognitive deficits or executive dysfunction. So you'd have to use it for the right person. Behavioral therapy is used for anybody. It's a matter of behavioral activation and structuring your week, setting activities, setting goals, relaxation exercises, getting people into anything else that would activate them is very helpful. Problem-solving therapy is sort of, in a way, it's kind of like behavioral therapy. It comes out of that a bit, but people with depression get sick in a context, and because of their depression and sometimes the executive dysfunction that comes with that, they can't solve their problems. They get overwhelmed. So the therapist helps break down their problems and order them and rank them in terms of importance and how to start doing it. And it's like doing an action plan sort of once a week to try and achieve goals and deal with certain problems. Okay, so there's some evidence that could be useful even in people who are requiring nursing care and have some frontal executive dysfunction. So again, not for dementia, but could be effective to help people, because you can't solve problems if the front of your brain doesn't work. And with depression, often the front part of the brain is just not working properly. Interpersonal psychotherapy has to do with 4 different foci. Focus could be on bereavement or grief. It could be on a transition, dispute, or interpersonal deficits. So bereavement is obviously common. There's lots of losses that occur in late life, loss of spouse, sometimes children, partners, friends, whatever. In terms of transitions, there's a huge amount of transitions that occur in late life, which include, retirement, moving from a home to a retirement home, or from a home to a long-term care facility, different types of moves and transitions in terms of roles and places. And even like transitions, we've done cases of people who've developed medical conditions, and there's losses inherent in developing arthritis or Parkinson's or stroke. People can't do what they used to do, and they're grieving that. So that's why interpersonal psychotherapy could be helpful around transitions, and grief is part of transition. Then I talked about disputes, so that's having arguments with people that really are triggering the depression, and interpersonal deficits have to do with people who don't have the interpersonal skills to, be able to develop a support network and to deal with the world, and you help them with their interpersonal skills through role playing and various things. The evidence for interpersonal psychotherapy is not robust. It hasn't been studied fully, but it has good, I'd say, face validity and good value, and I do a lot of it, and so do our trainees here. And it's easy to learn, actually. And then there's group therapy, which it was brought up, dynamic therapy, family therapy, not really well studied. It's hard to do these studies, and they're very, very valuable. We do lots of groups. There's groups running in our nursing homes. There's groups, so we have outpatients, all sorts of outpatient psychotherapy groups. We've done outpatient CBT groups. We have a geriatric day hospital here for mental health, people with mental health disorders. We do a lot of group education, group support, interpersonal group therapy. We've done cognitive group therapy. And I have a colleague who goes to the nursing home, a variety of nursing homes, and does groups there. And it's of great value, because people start to learn that they're not alone in their problems and in their depression, and there's similar themes when you get older adults together, themes of losses and transitions and medical issues, family problems, and it's great when you're able to get people together. So there's tremendous value. We also have a group here for people with dementia, early dementia and depressive symptoms to help them because as they're processing what's going on with them. That kind of support is wonderful. It's resource. It requires resource. It requires a couple of people usually to run those groups. You could do it one person running a group. Often we do two people, and the coordination sometimes is a little tricky, right? So I used to do a group in the nursing home here, and it was hard actually because of just the staffing and human resource issues. It was hard to get all the patients together in the room. I used to have to do it myself, and it took a long time just to get the patients together, me and a social worker trying to round people up. So, there's challenges at that level sometimes. And there's the issues around hearing. You need to have a great amplification system. We use pocket talker type devices where we have the microphone in the middle and people have their headsets. So it's not amplified. It's amplified into people's ears, but not into the room at large. So it's like pocket talkers for a group. It's really, really good. And then I do a lot of family therapy because people don't get sick in isolation. They get sick in their family context. Their illness affects their family members, and any sort of issues that are in the relationships will often get worse in the context of depression. I end up doing a lot of family and couples therapy, and so I got trained. Like I'm trained to do that. I'm trained to do interpersonal therapy and CBT. And so when I was a resident, I said I want to learn all these things, and it's of great use. So family therapy is really helpful because family problems can be perpetuating. And just some evidence around exercise. The guidelines for National Institute for Health and Clinical Excellence for Exercise found that they recommend structured, supervised exercise 3 times a week, 45 to 60 minutes, over 10 to 14 weeks at low intensity. That's a lot of exercise, actually. I'm not sure that everybody could do that, older adults, but there's certainly value in it. We know the importance of exercise in terms of cognition. In depression, there seems to be some evidence and recommendations as well. 60 minutes in a shot, 3 times a week, I don't see that happening. I go for more 20-minute to 30-minute. Now, I just want to run this case by you, just to illustrate some points, and then we'll get back to some of the questions. So here's a patient, JH, retired teacher with 2 children, married, got depressed after retirement. He has a history of 2 prior depressions remotely with admissions to hospital and ECT, so very sick, no suicide attempts. He has a history of an alcohol use disorder, and he drinks 2 beers a day. He has a history of benzodiazepine dependence, so he's on a benzo. He had hearing impairment and sciatica, terrible back pain, degenerative disease, and sciatica. And his hearing impairment was pretty bad. He was on a whole bunch of medications, including a bunch of benzodiazepines and antidepressants, and a whole bunch of things here. The family history of depression and a parent, grew up very poor, very little money, squalor, infestation. He was verbally abused and put down by his father, made to feel insignificant. He had low self-esteem growing up. He had a good relationship with his wife and children. His family were supportive. His MoCA was good. His GDS came at a 9 out of 15, which is high. He owned a rifle, which was a bit frightening for me. And the first thing we did was get rid of the rifle. So if we do a formulation to try and understand how to treat him, we'd start putting in all these things. So for example, predisposing is a family history of depression, is a past history of depression. He has problems with self-esteem that go back many decades. He grew up with poverty and verbal abuse. Perpetuating include his pain, his hearing impairment, his alcohol use, which could be a contributing factor. Certainly could be. He has ongoing self-esteem problems, and his retirement was a very big social precipitating factor. No longer feels useful, really affected his self-esteem. Doesn't have meaningful activity. Perpetuating alcohol and benzodiazepine use, no meaningful activities, no friends, and he still has a self-esteem issue. And protective factors, well, he has no major medical illnesses other than the sciatica, which is a problem, but he doesn't have any other major problems. Very supportive family, he has good insight, and is help-seeking. So you look at a formulation like this, you start to think of how we can treat this guy. And we'd say, well, you know, there's a few things. We know that he has no meaningful activities. His retirement was very hard. You know, this is maybe a good place for occupational therapy to come in and help him with goal setting. You know, any of us can do that, but I really like some of the things that occupational therapists could do to help you find this. And that might affect his self-esteem and improve it. He might need some psychotherapy for his self-esteem, whatever that kind of therapy it could be. It could be cognitive behavioral therapy because he has a core belief that he's not good enough. Could be. Or it could be interpersonal psychotherapy because he had a transition, which was retirement. Okay? And he's in pain. That needs to be dealt with. His hearing impairment needs to be dealt with. We also need to help him with his alcohol use and those benzodiazepines, all of things which are biological perpetuating and precipitating factors. Right. So this is why formulation would help, because it's not all about the medications. It's a matter of addressing the whole person and addressing the all the different factors that could come into play. So keep your eyes out in the next months. The new Canadian Coalition for Seniors Mental Health guidelines will come up, the update for depression, and that might be of interest to you. And now we have, I thought it'd be more time, but I guess I talked too much. But time for questions, if there are any. There was a question here, are social workers usually used in long-term care as effective as psychotherapists for residents? I'm going to say that the answer is absolutely yes. In fact, a lot of psychotherapists are social workers. Now, psychotherapist is someone who's been trained in psychotherapy, and there's family physician psychotherapists, there's obviously psychiatrists, there's psychologists, and there's social workers, occupational therapists, and nurses who have gone ahead and had additional training in psychotherapy. And in fact, there's not a lot of physicians. There's a lot of demand. It's expensive to have physicians do psychotherapy, and psychologists certainly cost a lot. So that there's a whole thought that most of the psychotherapy will be done by social workers, nurses, and OTs. So it all has to do with their training and their skill set. And there's a wide variety, right? So some people I've worked with had been doing psychotherapy for decades and trained by some of the best people, and others will have had different training and different experiences. So there's a question, that last slide, the Canadian Coalition for Seniors Mental Health. Please look at it. There's guidelines, updated guidelines for long-term care, suicide, delirium, and depression. And it's free. You just need to sign up there. It's a free thing. You could download it. Suicide prevention, delirium, long-term care, great guidelines. And now there's guidelines for substances in older adults as well. So that's called the CCSMH, Canadian Coalition for Seniors Mental Health. Okay, that's to answer that question.
Thank you, Rob. Are there any other questions today, or you're welcome to email us?
There's a question here. Self-esteem is listed as a major factor in this depression. Do you have an opinion on the research in mindful self-compassion suggesting role for self-compassion as a useful construct which is more resilient to health declines and mental illness? So I don't know what self-compassion, mindful self-compassion is. I know what mindfulness is. I'm not sure what mindful self-compassion is. I would say that these types of psychotherapeutic interventions can be very helpful, and it's a matter of choosing when to use it at the right time for the right person. So I would never say that something is not useful. I just don't know much about mindful self-compassion. If it's mindfulness that you're talking about, there's some evidence emerging that mindfulness could be helpful for mild depressive symptoms, but not a standalone treatment for a significant depressive episode. Here's another question. Spiritual care providers can also provide important listening and support for residents. Absolutely true. I think, you know, depending on the setting, we're lucky in our setting. Our nursing home actually has a spiritual care department through Baycrest, through the hospital, that they will go and visit many residents in long-term care and in the hospital. Spirituality is a great protective factor, actually, and you can certainly leverage that by having spiritual leaders involved, and I think that's a very good comment, so thank you.
Okay, great. Thank you, Rob. Dr. Madden, that was a great presentation. I see people are asking for the slides, so if we can send them out, we will. There certainly will be a link to the webinar that will be uploaded to the Ontario CLRI website. So thanks again, Dr. Madden, and thanks to all of you who joined. Please do stay in touch. Thank you so much. Okay, Rob, I'm going to stop us now.
Okay.
Okay, thank you. Bye, everyone.
You want some feedback? Are we still on the air, or are we closed?
We're still on the air. Hang on.
Okay. I think we're going to debrief, right?
Yeah. I'm going to call you on your phone. I think that's the best option.
Okay, thanks. Bye-bye.
Okay,
Bye-bye.
thanks.
Bye.
Bye.